Hello, my name is Joyce Ann Eclarino, and I will be talking to you about major depressive disorder. Major depressive disorder, better known as depression or clinical depression, is defined as a mood disorder that causes a persistent feeling of extreme sadness, isolation, and loss of interest. It's not like the occasional feeling of sadness or loneliness which normal people feel from time to time, but instead is characterized as extreme sadness, loneliness, or isolation persisting consistently for at least 2 weeks. Social, occupational, educational, or other functioning aspects of one's life must also be negatively impacted by the mood disorder. Major depressive disorder is also characterized by the presence of 5 or more depressive symptoms of the following: prolonged depressed mood throughout the day for multiple days, loss of interest and or pleasure in either all or most of regular daily tasks, habits, or other things that the person normally enjoys, severe weight loss when not dieting, or severe increase or decrease in appetite, insomnia or the inability to sleep, as well as hypersomnia, which is characterized as sleeping more than usual, issues with sitting still and also characterized by slowed movements or talking quietly or slowly, and daily fatigue, extreme tiredness or lack of energy even when doing menial tasks, as well as simple tasks taking longer than usual, having feelings of worthlessness or guilt, the inability to concentrate or think clearly, as well as recurring thoughts of death or suicide. Major depressive disorder causes a plethora of complications, including but not limited to the development of chronic disease, the misuse of drugs or alcohol, conflict with interpersonal relationships including family and friends, as well as diminished quality or productivity in school or work, and premature death. Based on a study done from 2005 to 2010 on the economic burden of adults with major depressive disorder in the U.S., it cost employers $216 billion, of which could be attributable to costs of treatment, absenteeism, and suicide-related costs. The study chosen for this presentation follows functional impairment in patients with major depressive disorder in 5 different countries in Europe. In order to better serve, prioritize, and alleviate the burdens of major depressive disorder, the effects of treatment and course of clinical action must be observed. The 2 objectives of the study include 1. To describe the course of depressive symptoms, perceived cognitive symptoms, and functional impairment over a 2-year study, and 2. To investigate which patient-related factors were associated with functional impairment. The study that was chosen was a 2-year prospective, non-interventional cohort study. The sample size was calculated via power, and the number of participants in each of the 5 countries are as follows. 29.4% from the United Kingdom, 29.2% from France, 23.3% from Spain, 14.2% from Germany, and 3.9% from Sweden. And these percentages were taken from a sample size of 1,159 patients overall. Patients were enrolled in the study by general practitioners and psychiatrists. Initially, 1,895 patients were screened for inclusion, but a total of 1,402 were enrolled in the study. The number of participants who have completed baseline and the 2-year follow-up was 1,159 patients total. The eligible age group for the study ranged from 18 to 65 years of age, and it included patients who were currently diagnosed with major depressive disorder and were either initiating antidepressant treatment or switching to their second treatment for the first time. Those that were excluded were patients who were diagnosed with another mood disorder, like bipolar disorder, dementia, schizophrenia, or other neurodegenerative diseases. Pregnant women and women who have recently given birth 6 months ago or less were also excluded from the study. Analysis was performed for individuals who had completed baseline and at least 1 follow-up questionnaire or assessment. Mean and standard deviation was calculated for continuous variables, and categorical variables were presented as either counts or percentages. Factors included absenteeism, presenteeism, work impairment, and activity impairment. Univariate analysis was performed to identify relevant factors associated with functional impairment. Patients' reported scores shown severity of relevant factors depleting over time, with the biggest change within the first 2 months of the study, and plateau at the 6 to 12-month range. Multivariate analysis included patient-related factors associated with functional impairment collected from the univariate analysis, beginning with month 2, month 6, month 6 and 12 combined, as well as month 18 and 24 combined. The reported severity of depression is directly correlated with factors associated with functional impairment factors. In conclusion, there was observable improvement regarding depressive symptoms and functional impairment. Reported functional impairment was associated with the level of depression scored from patients. The greatest improvement took place during the initiation of treatment or during the first switch to another treatment. However, cognitive impairment was found to not have as much progression. This finding may highlight the importance of possibly creating more effective or more efficient treatments for major depressive disorder to cater to both functional and cognitive impairment. A bias to consider for the study would be that the authors did not consider or include in their study patients who were using non-medication treatments or therapies for major depressive disorder. Some items that the authors may have not considered as well would be recall bias. Patients may not accurately report in their questionnaires accurate information or correct information. There is also response bias, where patients may have the tendency to answer questionnaires in means to give researchers desired results or other circumstances. In regards to the population study, the results from the study cannot be generalized to patients diagnosed with major depressive disorder in the entirety of Europe. Also, an item to consider is that the patients who were included in the study only involved patients in the early stages of major depressive disorder and does not include those with other mood disorders or ailments, and those who were on long-term treatment and psychotherapy. The ideal study design for the hypothesis or for the study topic would be to follow patients for a more longer period of time. That concludes the end of my presentation. Thank you for listening.